Hello, my name is Bethany, and in this vlog I'll be rehabilitating someone with an Achilles tendinopathy. My patient is a 20-year-old female who is a student but lives at home. She plays football 3 times a week and now has a grade 2 Achilles tendinopathy in her left ankle. During the subjective assessment, the location of pain was found to be near the heel and at the back of the leg. The history of the injury was that it developed while she was running on a hard ground, and it was exacerbated while she was playing football. My patient has never had an injury related to her left Achilles before or her left ankle, therefore her past medical history was cleared, as well as the red flags. During the subjective assessment of my patient, the SIN factor was documented. The severity of the injury is now low, with her VAS pain score being 3 out of 10. The irritability of the injury is low to moderate. This is because there is a dull ache when she runs on a hard surface, but this eases sometimes when she runs on a soft surface such as grass. The nature of the injury is inflammation of the tendon, which then causes the dull pain when she runs. During the objective assessment, I cleared the knee joint, in which the ranges of motion, muscle length tests and special tests were all fine for both left and right knees. On observation of my patient, I found that the left calf is smaller than the right calf. This is due to muscle atrophy of the left gastrocnemius and soleus muscles. I also noticed that the left Achilles tendon is bigger than the right, and it has more swelling and it looks generally thicker in and around the heel. During active range of motion of the ankle, the left ankle had 8 degrees less of dorsiflexion than the right ankle, and during plantar flexion, the left ankle had 10 degrees less than the right ankle. There was no pain during the movements, and the movement quality was much better in the right ankle than the left ankle. When I performed passive range of motion of the ankle, the left ankle had 5 degrees less of dorsiflexion than the right, and it also had 10 degrees less of plantar flexion than the right. The patient complained of no pain during both movements, and the end feel for both movements was firm. During the objective assessment, I got the patient to perform resistive muscle tests of the lower leg. For dorsiflexion, the resistive muscle test tests the strength of tibialis anterior and other muscles in the anterior compartment. And for plantar flexion, the resistive muscle test is testing the strength of the gastrocnemius and soleus muscles. For the right leg, for dorsiflexion, the patient scored a 5 on the Oxford scale, which means there is full strength and power in the right leg. For dorsiflexion of the left leg, the patient scored 4 on the Oxford scale, which means there is movement through range with some external load. For plantar flexion, the right leg scored 5 on the Oxford scale, and for the left leg, the patient scored 3, which means there was movement through range with gravity, but there was no external load. The patient also performed a special test, which was the Thompson's test. This is when I squeezed their gastrocnemius and soleus muscle, and if their foot moves ever so slightly, it means that the Achilles is not ruptured. Both the left and right leg produced negative results, therefore neither of the Achilles are fully ruptured. According to Crosley 2015, an Achilles tendinopathy is an overuse injury categorised by a combination of pain, swelling and impaired performance. Therefore, after a full assessment of my patient, I diagnosed them with a grade 2 Achilles tendinopathy. The first exercise we're going to do is a goblet squat to really strengthen the lower limb, and especially it's to load the tendon, the Achilles tendon, to make it strong. You pick up a dumbbell and have your feet slightly turned out, and then you squat and then back up and then squat, back up. If you try and keep your back straight and try and stay on the back of your heels. If we do 3 sets of 12 reps and then see how that feels. if you have your feet a tiny bit wider apart, and then when you go down, you'll be able to get down a bit further instead of leaning forward. Yeah, that's better. How does that feel?
Yeah, that feels fine.
Yeah, that's good. If the patient feels any pain or is unstable in the squat, I'd regress it to a bodyweight squat without any dumbbells or any weight, and just like that. And then to progress it when they build up their lower limb and their Achilles is starting to feel a lot stronger, I'd progress it to a back squat with a barbell. A goblet squat is a closed kinetic chain exercise as the distal limb is fixed to the floor. It is a very stable movement, and the muscles working are the gastrocnemius, soleus, hamstrings, quadriceps, as well as the core muscles. To progress the movement, I would add more weight to the dumbbell or progress it into a barbell back squat, and to regress the movement, I would decrease the weight and go back to a bodyweight squat. I would advise the patient to do 3 sets of 12 to 15 reps to develop their general physical preparedness, and then I would get them to rest between 60 and 90 seconds. When progressing the movement to a barbell back squat, I would get them to do 5 sets of 8 to 12 reps. This will help to develop their strength and get hypertrophy of the muscles. I would get them to rest between 1 and 2 minutes. The second exercise we're going to do is calf raises. This is going to help strengthen the calf muscle and inevitably strengthen the Achilles. To start off with, we're going to do a bilateral calf raise, just to get the movement correct. We'll aim to do about 3 sets of 12 reps. I'll show you how to do it, and then I'll see you do it, and then we can develop it. So you stand on the edge, put your feet, your heels over the edge, and then up and down. Up and down. And then to progress that, we will add weights. So add the weights, make sure you're balanced, and then up and down. Okay, we're going to do 3 sets of 12 reps. So to start off with, if you go on the edge, yeah, that's good. Yeah, that's good. Just try and keep your core tight to then help with balance as well. How does that feel?
Yeah, that's fine.
Yeah, and then what we'll do is add the weights. If you just do 12 reps again. How does that feel when you're Achilles?
Yeah, fine. They both feel alright.
Yeah, and then to progress this even further, we're going to do a single leg calf raise, which I'll show you. It's more for proprioception and to help with the strength of the calf. So you go up and down, up and down. You can use your foot as balance if needs be, and then down.
How many are we?
12 again.
Yeah, that's good.
And then to progress that again, you can try it with the load, but if that then hurts your Achilles, stop.
Okay.
Up and down, up and down. How does that feel?
Yeah, that's fine.
A calf raise is a closed kinetic chain exercise as the feet are in a fixed position. It is a stable exercise and the muscles working are the gastrocnemius and soleus. The The speed of the movement should be 1 second concentric movement and 3 seconds eccentric movement. I would get the patient to do 3 sets of 12 to 15 reps to start with for general physical preparedness, with a rest of 60 to 90 seconds, and then in another session I would progress it to 5 sets of 8 to 12 reps for a loaded double leg calf raise to develop strength and hypertrophy of the muscle. The load for this should be about 70% of their 1 rep max, and this should start off at around 30% of their 1 rep max and develop it to about 70. Third exercise is a single leg Romanian deadlift. That will help with the proprioception of the lower limb and strengthen the calf muscle as well. So what I'd like you to do first is do it on your non-injured leg, and you're going to try and keep your core engaged, your back, like your shoulders back, and then you're just going to lean down and then back up. You're going to do 3 sets of 12 reps again. Just keep doing that, keep your core engaged, your back straight, and if there's any pain, stop. But do your non-injured leg first. Okay. Yeah, if you try and keep your shoulders back and then engage your core, and then to then keep that stable, so then it predominantly works your leg rather than just trying to bend down. If you try and keep it straight, you'll be able to go down and it more focuses on your leg. Yeah, that's good. How does that feel? Yeah, that's good. And then if you try the other leg. Yeah, keep that core engaged. That's good. And then to progress that, we will add a weight onto it. So when you bend down, you drop the weight, but try and keep the core engaged again, and then back up. Like that. Try and keep your back straight and your core, tense your core when you go down, so then you can keep that back straight. Yeah, that's better. How does that feel?
Yeah, that's good. Yeah, that feels fine.
A single leg deadlift is a closed kinetic chain as the distal limb is fixed to the floor. However, it is an unstable movement due to it being a single leg. The muscles working are the gastrocnemius, soleus, quadriceps, hamstring, as well as the core. To progress the movement, I would add more weight, and to regress it, I would use less weight or use a gliding board. To start with, I would do no weight, and I would get the patient to do 3 sets of 12 to 15 reps to develop general physical preparedness with a rest of 60 to 90 seconds. And I would then get them to use a kettlebell and do 5 sets of 8 to 10 reps to develop strength and hypertrophy with a rest of 1 to 2 minutes. Overall, all the exercises went well with my patient doing them to a high standard. They needed a couple pointers but performed them well after she knew how to do the exercises correctly. The successes were that the patient had no pain whilst performing the exercises, and the Achilles tendon accepted the movements well. As the patient had good technique, they were able to progress the movement by adding more weight to further strengthen the Achilles and the calf muscle. A couple things I could have done better was performing the exercises to a high standard for all of them, so that my patient was able to copy the correct technique. I could have also said different cues throughout the movements to make sure each rep is performed correctly by the patient. During the next couple of weeks, I will reassess the patient for their range of movement as well as their knee to wall test to see if there was any improvement. I would also see if there is any visible differences in the calf sizes, and I would ask the patient if they get any pain when they run and further monitor this. I would also see if the patient starts to lift more when performing lower limb exercises that involve the calf, and I would progress the patient to lift more and start running more when possible. I'm Bethany. and thank you for watching my vlog.